We're going to get started with our invited speaker section, and we're really happy they all accepted our invitation to come and speak. The first is impacts of extreme heat and the other climate-related environmental exposures on mental health. I'm pleased to introduce Dr. Amruta Nori-Sarma. I am not going to go through the full bios, but I want to direct you to page 7 of your conference book for full bios on everyone who are extremely accomplished people. What I will say about Dr. Amruta Nori-Sarma is she's an assistant professor in the environmental health department at Boston University School of Public Health, where she studies the relationship between environmental exposures associated with climate change and health outcomes in vulnerable communities. Thank you so much, Dr. Nori-Sarma, for coming today and to present. Come on up.
Thank you so much for the kind introduction. And I know I have about half an hour, so I'm going to try to stick to my time. I'm Amruta Nori-Sarma. I'm very happy to be here with you today to talk about some of my research looking at the mental health impacts of different types of climate-related exposures. I'm also going to share a little bit of information with you about our new Climate Change and Health Research Coordinating Center, which I'm one of the 3 MPIs for from the NIH. So let's see. All right, there we go. So I'll get started with a little bit of background. I don't think I need to convince anybody here that climate change is an environmental exposure threat that's continuing to have really dramatic impacts on health globally. Of the 10 warmest years on record have all occurred since 2010. And this is in our available 142 years of temperature data that we have for the globe. And I think, in fact, 2023 is going to probably also top that list as well. And we know that climate change is going to lead to more extreme weather events, including heat waves, but also storms, wildfires, droughts. So I know that folks in the room are broadly more focused on the mental health side. I don't actually have a background in mental health. My training is in environmental epidemiology, and I've been really interested in mental health as one of the most pressing concerns that we have associated with climate exposures. So a lot of the work that I've done is trying to characterize the health burden associated with climate-relevant events. And so the example that I'm going to be diving to in a little bit more detail to share with you some of the ways that I've been thinking about environmental exposures and especially extreme heat and other types of extreme weather events is based on this paper, which you can find online, looking at the association between ambient heat and the risk of emergency department visits for mental health among adults in the US. And hopefully I'll be able to also share with you some of the ways in which similar work could be conducted in the Africa context. So the impacts of elevated heat on specific mental health outcomes has not historically been very well understood. We know a lot about the ways in which physical health is impacted by extreme heat, but mental health has been really understudied. So the work that I'm sharing today was aiming to quantify the association between ambient temperatures, specifically extreme heat, and mental health-related emergency department visits across the contiguous United States among adults. So this is people age 18 or older. And I looked both at overall mental health causes as well as for specific subsets of mental health. We also looked at effects in potentially sensitive subpopulations. So are there meaningful differences in the rates of emergency department visits for the elderly versus younger adults? Is gender an important characteristic? And also the US is very heterogeneous in terms of the climate exposures that we experience. So I wanted to look at whether there were particular parts of the US that were more susceptible to these risks. So I'll tell you a little bit about the exposure data set that we have. We looked at county-specific daily maximum ambient temperature, and this is based on an existing spatial model that combines satellite data with ground truthing from monitors. It's called the PRISM model. And what we did is we were able to take that across the entire US and develop localized estimates of population-weighted extreme heat. We defined extreme heat as the 95th percentile of the local temperature record. And so you can think about this as a comparison of about the 5 or 6 hottest days every summer to the coolest days in the same summertime period. And this is what that map looks like across the US. So this is taking a global model of temperature data and downscaling it to these little areas. Let's see, I think there's a laser pointer. It might be difficult to see, but these little areas are zip codes throughout the US. And what you can see from this map is the areas outlined in purple are the different climate zones that we have across the states. And you can see that the temperatures are very different depending on if you're in the northern part of the US compared with the southern part of the US. So that's why we do the relative temperature threshold for looking at the health effects of extreme heat, as opposed to looking at absolute temperatures. In terms of the outcomes, I think this is the bulk of the work that I've been really interested in. So we were able to use a database of commercial health insurance beneficiaries. So the other thing that I think is one of the strengths of the approaches that I'm using is that we're looking for these large-scale big data sets that we can use to try and identify the health outcomes that are going to be most relevant for some of these climate exposures. So this is a commercial insurance provider in the US. It's called United Healthcare, and they manage a de-identified data warehouse of commercial and also a few people who have supplements to their public health insurance. And so what we were able to extract from this data set is over 3.5 million emergency department visits specifically for mental health outcomes among 2.2 million individuals across the entire US. And this is in the summertime from 2010 to 2019. And so what this is it's a de-identified longitudinal health data set on enrollees and patients, and it represents a really diverse mixture of age groups, ethnicities, and geographies across the continental US. So here's just a list of the number of emergency department visits by cause, the mean number of daily visits for each of these different outcomes. And so you can see that we have one catch-all for any mental health endpoint. It's based on diagnostic codes, so ICD-9 or ICD-10 codes. And then we also have listed in order of most frequent to least frequent all of the specific mental health endpoints of interest. And maybe not surprisingly for a lot of people in this audience, the most prevalent outcome that we have in the data set is substance use disorders. And this is what that map looks like when you're looking at the number of daily emergency department visits in those same zip codes across the US. A very important thing to keep in mind about this data resource is that just because a lot of us are coming from Boston. Boston is kind of in the upper right part of this figure, highlighted in very dark blue. So might indicate that there are a lot of people visiting the emergency department. I don't think it's because there's a huge overprevalence of these health endpoints. We might just be seeing the fact that it's commercial insurance beneficiaries. So the important thing to keep in mind is that it depends on having access to commercial health insurance, which is a huge disparity that exists in the US healthcare system. So in order to deal with this issue in the data, we know that there's not the same number of enrollees in different parts of the US. So I use what's called a case crossover study design. The case crossover is a comparison of individuals to themselves over time. So it allows us to control for potentially time invariant characteristics like the aspects of your neighborhood that might change very slowly over time. And therefore, what we're really doing is, let's say somebody visits the emergency department today on Saturday, we're comparing today's data on the environmental exposures to last week on Saturday and next week on Saturday to say, is there a particular reason why this Saturday is the day that you went to the emergency department? And could that have something to do with the acute environmental exposure, like the extreme temperature, the heat wave, or some other characteristic that's acutely changing that led to this emergency department visit? And the time stratified approach allows us to look at the same year, the same month, and the same day of week. So as I mentioned, characterizing the numbers of visits happening across time. We also adjusted for other important meteorological characteristics, so not just heat, but also looking at humidity. And then in the US, more people go to the emergency department on regular days compared with federal holidays, so we controlled for holidays as well. And what we found was pretty stark. So we found, this is for overall mental health, and we translated the relative temperature thresholds to absolute temperatures on the horizontal axis, and then on the vertical axis, we're showing the incidence rate ratio. So this is comparing this temperature to the minimum morbidity temperature, which is the lowest temperature of each summertime period. And we found that there was pretty much linearly increasing rates of emergency department visits as temperatures were increasing. And this was very significant. It's also very acute. We're able to look at multiple lags. So is today's visit associated with today's temperature, or is today's visit associated with yesterday's temperature or the temperature from a few days ago? Turns out it's mostly today's visit is associated with today's temperature. And we looked at this same model across each of these different mental health endpoints that I mentioned before. So, sorry, the labels are a little bit small, but it starts in the top left corner with the most common substance use disorders, and then in the bottom right is the least common adult personality and behavioral disorders. And what we found is that these linearly increasing trends in rates of emergency department visits for any mental health endpoint are persistent even when you're looking at these very different mental health causes. And again, looking at the lagged association, it's a same-day effect. It's not that multiple days of extreme heat are impacting people's mental health. So here I just highlighted the comparison of the 95th percentile of the local temperature with the coolest days. So you can see that these are pretty significant increases in the rates of visits. So, it's 8%, anywhere from 5% to 11%, depending on the cause. But you can think about that propagating through 3 million emergency department visits occurring in over 2 million individuals, and suddenly a 5% increase in the rate of emergency department visits looks like a huge burden on the healthcare system. And the other thing that I've really been thinking about is, how do we define what extreme heat is? What are the comparisons that we should be making for these climate exposures? If a day wasn't the 95th percentile of temperature, do we really expect it would be the coldest day? So is that the right comparison? Or do we think that an extremely hot day under normal circumstances might just be a kind of hot day? So to try and start addressing this question, I looked at the comparison of not just the most extreme heat days to the coolest days, but the 80th percentile of temperature. So now we're starting to get into the 15 or 20 hottest days of each summer. And we still see persistent increases in the rates of emergency department visits. So this indicates that it's not just the very extreme hot days that are influencing people's mental health. It's also some of those more moderate days that are having some sort of negative impact on people that is causing the need to go and seek emergency care. So I mentioned we were looking for potentially vulnerable subpopulations. And the nice feature about this large data set that we have is that we can start to look at heterogeneity in these effects, depending on if you're in different age groups, if you're male or female, or depending on where you live in the US. And there are a couple of things that I want to highlight from this component of the work. The first one is that for a lot of the other health outcomes that we're really concerned about associated with extreme weather and with climate, we're really concerned about the elderly. So for physical health endpoints associated with heat risk, we're very concerned about older individuals. It's a very dangerous environmental exposure. And we don't actually see that in the mental health claims. So in fact, we see that across the board, extreme heat is a risk factor for increased emergency department visits, whether you're a younger adult or whether you're an elderly adult. Another component of this that I want to highlight, just thinking back to what we saw in terms of the temperature map. So in the northern parts of the United States, it tends to be a little bit cooler, and in the southern parts of the US, it tends to be a little bit warmer. But we actually see higher rates of emergency department visits in the northern parts of the United States where the temperatures are cooler than we do in the southern parts of the US. So I think that speaks to some adaptive capacity that's happening in places where they're already experiencing higher temperatures. So maybe it's hotter in the southeastern US, but there's more air conditioning. So people aren't necessarily visiting emergency departments at higher rates. So I'm just gonna wrap up about this particular work. We found that days of extreme heat were associated with higher rates of mental health related emergency department visits. I feel that these results can be really informative for clinicians across the US and maybe in other contexts as well, who might have to provide more services for their patients during periods of extreme heat. One of the things that I've been thinking about, and I know other researchers are as well, is that particularly for clinicians, this type of information is really relevant because the causes that you're coming into the emergency department for might look very similar, even if they have different underlying exposures that are leading to them. So, for example, what we're seeing now in the Boston Medical Center data is that patients who are coming in with psychosis, the symptoms of psychosis are very similar to the symptoms of extreme heat stress. So maybe it's important to understand what the environmental risk factor was so that clinicians can then make an informed decision for how they treat their patients, because maybe the treatment is different if you have a heat stroke compared with if you're having another type of health event. So one of the questions that has been really under conversation is, what are the potential pathways? What are the explainers for why we see these effects? From the environmental exposure, are we back? Yes. From the environmental exposure to the mental health endpoint. Daytime discomfort is also potentially an explainer. We know that people get more irritated during heat waves. There's actually recent literature showing that people get more violent during extreme heat waves, and that these incidents of violence tend to be tied with things like the urban heat island and places where heat is even more concentrated in smaller and smaller locations. And one of the other things that was mentioned during the keynote is the increases in hopelessness, maladaptive anxiety, and stress. Sometimes these things together are referred to as eco-anxiety or solastalgia, due to the anticipation of climate change and associated extreme events. And I think this is one of the reasons why it's really important to also look at the need for healthcare among younger adults, because we're now coming into a generation of young adults who have never lived in a world where climate change wasn't an existential threat. So it's going to continue to be a factor that's impacting people's mental health. So we do have a couple of limitations in this work, which I wanted to just highlight quickly. We focus on emergency department visits, and that's because this is the data set that we have. But so there may be a lot of folks who are experiencing adverse mental health outcomes who are having subclinical or interactions earlier in the clinical care spectrum. There are going to be some folks that we might never even know that they're having an adverse mental health event because of their extreme heat exposure or because of their other climate relevant exposure. In the data set that we have, it's, as I mentioned, de-identified, and that happens in-house at the Optum Labs data warehouse. So it doesn't include some individual markers which are really important, including race, ethnicity, socioeconomic status, occupation, and also one of the big characteristics that we're really interested in from the environmental side is time activity patterns. So we're assuming that the temperature exposure in your zip code is a relatively good proxy for the extreme heat that you experience. That may or may not be the case depending on, what your indoor conditions are like, what your commute to work is like. So there are a lot of different characteristics that might influence your exposure. We also didn't consider in this particular work other meteorological characteristics that I think might be really relevant. So let's extract a little bit away from this particular work and talk more about what are the opportunities for conducting this type of work in other settings. So similar to the heterogeneity of the climate classifications across the US, and the map that I showed earlier is from our National Climate Assessment, there are multiple ways of classifying climates across the globe. One of them is the Köppen-Geiger climate zone classifications. And I think one of the things to keep in mind in the Africa context is that there are these large zones that have relatively similar climate characteristics. And so I think this might present opportunities for people who are interested in conducting similar work, looking across multiple different parts of the continent, but understanding that there may be heterogeneity in some of these effects based on what are the local climate conditions. And so the reason why I wanted to highlight this is because I think it's important to consider, especially when you're looking at who are the people who are going to be relatively vulnerable, considering the baseline characteristics of these different areas. So the African continent obviously has very diverse climatological zones, and I just think it's important to take that into consideration if there's interest in doing this type of work. So I pulled out some examples of climate-relevant exposures that are relatively recent. This is from a couple of days ago where there was an extreme heat wave locally. But the reason why I've been really interested in looking at different types of climate stressors is because in the US, like I think in many other parts of the world, people aren't just experiencing one type of climate event. So if you're in a heat wave, you may also be in a drought. You may also have a wildfire nearby that's impacting your ambient air pollution levels. On the other hand, if you're in a relatively cold period, you may be experiencing flooding or other types of storm events. And more, I think, across the world, what we're understanding is that the implications of multiple climate stressors are that it's more than just the sum total of each of these individual exposures. That the impacts, especially on mental health, from being repeatedly exposed to multiple stressors is going to be additive, or more than additive. It's going to be almost exponential in terms of the impact that it has on the need for care. So this is an example of heat wave. Here's an example from a few weeks ago of flooding. So these things are also occurring relatively close together in space and in time. And people have to be more prepared to handle the potentially different needs for patients who are presenting to emergency departments or to clinical settings because they need care following each of these very different types of climate events that they're exposed to. There's really good data on ongoing drought conditions in different parts of the continent. So another thing that is very common with heat waves is that they're co-occurring with drought. And we know that access to water resources is one of the main predictors of good health during these extreme heat wave periods. And this is actually from today. This is the air quality near Lagos. And the reason why I wanted to highlight this is because this is a publicly available air quality index that's online. The link is at the bottom. But what you can see is each of these red images in the picture is a place where there's a wildfire occurring. And you can see the impacts that wildfires, which of course are associated with climate, are having on local air quality conditions. And air pollution, we think of this as a climate forcer, but it's also something that's a negative feedback mechanism, because as the climate continues to warm, there may be more wildfire events, which will in turn create these systems of higher air pollution exposure in different communities. And then this is just an example of climate-induced desertification in northern Africa. So again, one of the things that we have to take into consideration in these questions about climate impacts on mental health is how are the local environments changing? So areas that have classically been dry are going to be experiencing more desertification and higher levels of drought. So I'm going to switch gears a little bit in terms of thinking through how do we start to provide some solutions? How do we start to work together to not just understand the health impacts of climate change, but also working to reduce those health impacts? So this is a really exciting initiative. I think Christina is going to be talking about it a little bit in more detail tomorrow. But the National Institutes of Health have a new climate change and health initiative, which is very exciting because it's across multiple institutes at NIH. And I'm one of the 3 MPIs of the new Research Coordinating Center, which is joint between the BU School of Public Health and Harvard School of Public Health. This is our website, climatehealthcafe.org. I just wanted to share a few of the resources, maybe as ideas for how all of the work that you all are doing would be really excellent as part of the global community of practice that we are working to build for CAFE. So one of them is that we are setting up a data repository. It's called Harvard Dataverse, the Climate and Health Cafe. And what this is so, for example, the PRISM data that I used for my project that I shared earlier, this is a global spatiotemporally validated model of temperature, and we're making it available through the Harvard Dataverse so that people who are interested have all of the information on how to create local data sets on extreme heat and on temperature. And side by side with the Harvard Dataverse, we're also creating GitHub, which will have all of the code that you would need in order to load the exposure data and use it with your own health data resources. So we're hoping, these are things that we're hoping to make available to the community of practice more globally. And a couple of other really exciting initiatives that we have. We're gonna have an annual meeting in February, and that will be conducted virtually. And we're really hoping that anyone who's interested will propose roundtables or propose sessions or present posters. And you know, this community of practice that we're working on is only as strong as the representation that we have from different researchers around the globe. But we're hoping that this will be a really exciting way to connect folks across different communities that are interested in working on climate change and health. We also have a pilot funding mechanism that we'll be administering, which is going to be opening next week, or maybe not next week, but the following week. And then there will be a broader mentorship network, we'll have a newsletter, and there will be other resources available as well. So if anyone is interested in any of these items under CAFE, feel free to connect with me as well. And I think that's everything that I have for today. So let's see how I did on time. I think I'm good. Thank you.
Good afternoon, everyone. My name is Oluyinka. I'm an African from Nigeria, so I'm curious about the data on Nigeria. Thank you, Ma, for pointing my attention to it. So I am curious. So the data talking about wildfires and all of those in Nigeria and the quality of air, where did that come from?
Yeah, this is from OpenAQ. There's an AQ air quality inventory that they conduct. It's based on stationary monitoring data, and then also there's community participation. So I'm happy to share with you the link for OpenAQ data. It's available in different. So it's interesting because a lot of air quality indices are the method for translating from the absolute levels of particulate matter or absolute air pollution levels to an index is a little bit opaque, but I like OpenAQI because they provide some information on their algorithm. So they won't provide you with the current air pollution level is 200 micrograms per cubic meter of PM 2.5. They'll say the current air quality index is poor, moderate, healthy, right? But I think the reason they do that is because the levels aren't necessarily translating from place to place. Like there may be higher baseline levels in one area versus another area. So they're trying to provide a local context as well as give an idea of the current air quality. But yeah, I can provide you with the information on the website.
Yeah, thank you so much. Really interesting work, and I'm so glad that you are here. I was just wondering about trying to take what you're doing and then whether there's any room or need for sort of smaller, maybe sub-studies, qualitative perhaps studies of actual clinicians interviewing patients in these during the heat waves or whatever, to see what, because it is, I agree that I think it's interesting, the mechanistic stuff is really interesting, and maybe will come out of the zeros and ones that you do, but maybe perhaps also will come out of some qualitative sort of interviews as well, just to have a really sort of granular understanding of what's going on during those times.
Yeah, that's a great question. And we have an ongoing collaboration with BMC, and we're starting to do patient interviews in the psychiatric emergency services at BMC. And I think the upcoming plans are to also start interviews with clinicians who are providing care in PES. So that is one of the components that we're trying to integrate into this overall research. But I think that one of the things so there are a couple of things that are important to keep in mind, and I was mentioning this in one of my conversations earlier. When people see the results of this larger study, I get kind of two response pathways. So the first one is clinicians that I've talked to will tell me, of course, there are a lot of people who come to the emergency department during a heat wave. It's air conditioned, it provides some climate control. So it may be about the need for emergency care. It may also be about the need to escape their contextual environment, right? So that's one end of the spectrum. And then the other end of the spectrum is clinicians who say, I have no idea what you're talking about. We don't see a surge in patients in our emergency department. And, I think both could potentially be true. But in order to gain that context, I do think that those individual level conversations are really important to understand, do you see the surge in care or in the need for care? But also to talk to the patients to understand, what is it that brought you to the emergency department today? Are you seeing an exacerbation of your existing mental health condition? Is this a new condition for which you need treatment? Or are you coming into the emergency department because there's something about your local environment that's leading you to have this adverse mental health impact?
Really interesting work, thank you. Just a quick one though. How much more, can we tell from the data, how much more of an increase there is for people with mental health conditions versus people without?
Yes, so that wasn't a part of this study. We can tell from this data. We can tell because individuals can be tracked over time. So each patient has a unique identifier. So we can tell if this is their first visit to the emergency department, or we can tell if this is a subsequent visit to the emergency department. It's difficult to know just based on emergency department records because people may have previously been receiving clinical care that wouldn't necessarily get captured in this data set. The other thing is that commercial health insurance is a really big problem in the US because there are so many criteria for who has it and how you get it. A lot of access to commercial health insurance is through your employer. So you may have some choice in who provides your commercial health insurance. You may not have a lot of choice. And at the end of the day, if a person loses their coverage, we don't know what's happening to them when they lost their coverage, right? So the way that we're trying to address this gap in the research is that I have some funding to look at Medicaid beneficiaries. So Medicaid is the public insurance data in the US, and it's similarly criteria-based, but the criteria is poverty thresholds across the US. And some places recently expanded access to Medicaid after the Affordable Care Act. So we're now looking to see if we find these persistent, elevated rates of need for care in the Medicaid beneficiary population. So hopefully that will help us to address some of the more vulnerable folks, and then also looking more long-term to understand some of those questions around, is this a subsequent emergency department visit, or is this the first one that a person experienced?
Thank you so much for your comment on sleep. I'm so glad it's being included now. So that's really relevant. And with all our research at the moment, I must say we haven't thought about looking at climate change at all. But it's fascinating to know that sleep really thrives around about 18 to 20 degrees centigrade. So you can imagine how it impacts on sleep. So I should imagine you've probably got an increase in anxiety, depression as well. And then the long-term effects would also be on productivity during the day.
Yeah.
Thank you so much for an excellent talk.
So I just want to follow up on that because I think that there are a lot of folks who do climate relevant work that they may not know yet that they're doing climate relevant work. And I think that might be true for a lot of people who do studies on mental health, because once you have the challenging part is getting the health data. The climate data is relatively well accessible and hopefully only to become more accessible as we start creating some of these standard operating procedures and looking for global data sets. So I think if you have the health side of things, tying in the environmental risk factors is, relatively easy compared to the amount of effort that goes into collecting the health information. So a lot of people who could potentially be doing climate work that just don't know it yet. Yeah, sure.
Sorry, I'm not letting you finish.
It's fine.
Do you know if there's much work on the relationship in the other direction? So does better mental health make us better global citizens? Do we look after the climate better? Because perhaps, that's an important argument we need to be thinking about and making.
Yeah.
That the promotion of mental health, it probably makes people look after the planet a bit better.
That's really interesting. I have to admit, I have no idea how I would address that question in this data. I mean, I guess in theory, one would anticipate that people, if a society on average has better mental health, maybe their local environmental conditions are better. I know there's a talk coming up maybe later today or tomorrow about urban green space, so that might be one example of how you could measure the potential benefits of better mental health in the local context. But one of the things that I think came up earlier, which is very true, is that climate change doesn't really respect boundaries. And also the people who are experiencing climate change aren't necessarily responsible for creating the climate change that we're experiencing. So it's also hard to know how much of it is these broader systemic issues versus how much of a really local impact is there. I don't know the answer to that question, but it would certainly be interesting. Yeah.
One last thing, do you mind just commenting?
Who can access your technical assistance center? The grant that you just.
That's exactly what I was just, the cafe,
Oh.
if you can talk a little bit.
Yeah. Sure. So CAFE is intended to be for the global community of practice. So anyone is open to connect with us. These resources that we are providing will be publicly available. Things like the Dataverse collection, the GitHub repository are only as good as the data that we're getting fed into it. So we're hoping that this will create a transparent and reproducible system for anyone who's interested in conducting research. And if people find better data sets than what we're offering, we really want to know about that, because we want to give researchers, and especially early stage investigators and investigators from underrepresented backgrounds according to the NIH definitions, we want to give those people access to the resources they would need to accelerate their work and get credit for the work that they're doing. So if anyone has a better temperature model than the PRISM data that I've used, and they really want every researcher out there who's doing climate change and health work to know about it, we would love to have them put their data on the Dataverse repository and get the credit for it through our API, so that any other researcher who's downloading that data knows who they should acknowledge in their work that they're doing. The pilots that we're having are, I think, again, open. We're prioritizing pilot awards to researchers from underrepresented groups, to researchers from low and middle income countries, and to researchers who are studying communities that have historically been heavily impacted by climate exposures. And the annual meeting is open to all. And the structure of the annual meeting is going to be hopefully conducive to a lot of dialogue and conversation. So as I mentioned, it's a virtual meeting. It will be held from February 5th to February 7th. We're hoping that we can just be the facilitators. So if someone in this room wanted to propose a session that would be open for anybody in the global community to talk about the intersection of climate change and mental health in Africa, we would provide you with the platform to do so, and we would help you and support you to bring together the roundtable and the researchers, and we would just be the host of that. We're really relying on the community of practice to lead on those conversations. So I know that was a long answer to your short question, but. That's great. Thank you so much. Of course. Thank you.